see the crew come up to the patient, establish the patient is unconscious, no pulse. They will immediately begin chest compressions. You see them in the process of deploying the auto pulse with the quick case. They'll make sure that everything's prepared appropriately with the auto pulse, that the auto pulse is on, that the auto pulse band is open, the quick carry case is in the proper position. Prepare the pads, the defibrillation pads, so that this happens, the time off the chest is very short. They will then sit the patient up, stop compressions. We want to limit this time. Slide the auto pulse underneath the patient, lay them back onto the auto pulse. They will put the auto pulse band together, immediately restart the auto pulse so the time off the chest is as little as possible. Then they will place the straps to appropriately hold the patient in place on the auto pulse, and then deploy the quick case so that they can move the patient quickly onto a gurney. Because nothing trumps compressions, nothing. We set our auto pulses up so that they do continuous compressions regardless of the airway that we're utilizing. We place a patient on a gurney right after we place them on the auto pulse, and we use the gurney as a tool for intubation. Much like they do in an OR or in an ED, we'll place a patient on the nasal cannula at 15 liters, and when our medics are intubating, they have all the time in the world to intubate. We keep an eye on their saturation, and we keep an eye on their end-tidal CO2, and they're getting plenty of oxygen, and they're blowing off enough CO2 that they can take as long as they want to intubate, as long as those numbers stay good. Once we get the tube in the proper spot, the rescue pod goes on, and then the end-tidal CO2 sensor. We do it in that way on purpose to keep some of the debris out of the end-tidal CO2 sensor. The rescue pod helps us with blood flow, so getting blood down into the heart and out of the brain and blood into the brain. It increases perfusion. It's a blood in, blood out process. And so the rescue pod helps us with that. And then we base all of our treatments off the end-tidal CO2. You'll notice that initially or immediately after we've intubated our patient and placed them on the end-tidal CO2 in the rescue pod, we'll sit them up. So we base our defibrillation choice on where the patient is with their capnography. We use capnography to basically measure where we are with pH, and we have to get the pH and the saturation of the heart and the blood straightened around before the heart's ready for defibrillation. So as you can see, if the patient has a good end-tidal CO2 of over 20, then we will choose to defibrillate coarse VFib. We don't defibrillate fine VFib, but we defibrillate coarse VFib. If the end-tidal CO2 is below 20, then we'll withhold defibrillation until we get the patient and their pH and their end-tidal CO up to a level where we can appropriately defibrillate and successfully defibrillate.